pathogens, and going back to like fetal alcohol syndrome, very big. You know, we talk about special needs next week. Next Tuesday, I have to think for the break and all, but yes, next Tuesday when we're here, we're going to talk about this coming up. You know, a lot of cardiac defects. So again, what parents exposed to in utero. And sometimes we don't know what it was. But many other congenital anomalies go along with this too. So, for example, there are certain, like usually these children have microganthia, like small chins. They have smaller heads, microcephaly. They have sometimes Down syndrome. So, you know, there's other congenital spectrum of things that have gone on. And when they genetically look at the child, there's a lot of areas where genetically they have trisomies, more trisomies than monosomy. We really have a few monosomies, but a lot of. So again, a lot of times it comes along with other congenital defects. Usually when there's a problem, again, with the development in this area, there's other areas too. Those are the most common things. Again, it causes a whole multidisciplinary team to become involved with these issues. And again, upright feeding, nasal regurgitation is not harmful, so that's why we focus on the psychosocial here, because usually physically they do very well. The biggest thing post-operatively is making sure that, first of all, after the lip surgery, they're not touching at that, and nobody's scrubbing or cleaning the suture line very well. So this comes up as a question all the time, because students will say to me, okay, so you told me I don't want to be cleaning the suture line, and then I read that I do want to be cleaning the suture line, and then somewhere else it says don't clean the suture line. Do you clean the suture line after feedings or don't you? You do. You want to clean that suture line after feedings. You don't want to rub at it. You want to dab it. You want to clean it with normal saline. You don't want to clean it with any products like betadine or anything that might be caustic to the area. But you do want to rinse it or clean the area very gently afterwards. And eventually, as I be moving to PO, again, you want to protect the incision site. If they're older, you don't want them putting anything in their mouths, especially when the cleft palate closes. And comfort measures, you don't want them crying a lot. These are infants you would not put in the prone position, obviously. You don't want them putting their head and rubbing that suture line or anything. And sometimes they will use restraints on them, Bill.
How long are you keeping them with like nothing in the mouth or anything?
They can eat, but you don't want them having, like if they're older children, you don't want them sticking things in their mouth. Kind of like people with tonsillectomies that you don't want. You know what I'm saying? It takes the cleft palate and the cleft lip about a week to really heal up enough that you're not going to be able to damage those suture lines.
They can still eat though.
Hmm?
My question is basically that,
yes,
like,
absolutely. They're eating. You don't want them eating. Think of it like tonsillectomies. You don't want them, if they're older children, you don't want them eating like pretzels. Yes, stuff like that. Chips. Yes, chips. That's right. That's what it is. Chips and stuff like this, right? You want them eating the things that are like, you know, like the softer foods. You know, soft pastas. Nothing too hot, obviously.
Infants 3 to 6 months can they still be breastfeeding?
Absolutely. Yep, absolutely. You want them to feed normally, and they would just dab and very gently clean the site afterwards.
My niece actually had a palate. She had no other anomalies or anything, but when she was a baby, she used to have like milk would come out of her strange.
Yeah.
And she had a surgery, I think, when she was like 2, and she had another one later on. And she had issues with orthodontics, like teeth came in like really strange positions. She had tubes in the ear, she had frequent ear infections, so it was all kind of stuff.
All interrelated. That's absolutely right, and that's why I said it's like a multidisciplinary. They definitely need an ENT because the ears, the eustachian tubes are usually affected. They do have frequent ear infections. All those things Melissa said are absolutely right. You're going to find that they're going to have issues with teeth later on. Even if it's corrected at a very young age, the teeth when they come in still will have positioning issues.
Sideways, you know, like double behind, some of them came in, the other ones didn't fall out. Yeah, literally.
Yeah, it all happened. And again, it's because of the, you know, the teeth are developed in utero even. You know what I'm saying? So when everything develops in that way, even if you correct the palate, it's still going to have issues when they finally come through, even the permanent teeth. So, but it's very correctable. I mean, no permanent problems in terms of physically. Do you know what I'm saying? A lot of it is just the psychosocial aspect.
She had braces for years, and yeah, tubes when she was let off, and like 2 surgeries.
Well, like you said, you would look at her and you wouldn't know anything's wrong.
No, she's like 16 now.
Exactly. And that's and so really it's about parents. And the reason why I say that is because parents have a vision. I mean, I know you did this with Ms. Stormsky, so I don't want to belabor it, but you know, parents have a vision when they're pregnant and at the end of the pregnancy, right? You guys did this with Ms. Stormsky about the different psychologically what women go through, right? And is the baby going to look like me? or is this or that, right? And then if you don't expect and the baby is born with something like this, you know, it's very hard for parents sometimes. So what you want to stress to them is, like, what would be techniques you could use if you were the nurse and if the baby is born with something?
Like, obviously, you're gonna say, you know, it doesn't affect them, you know, physically, they still eat, they still nurse, and we can fix it relatively young, and they usually have really great success rates.
Yes. What else? Go, Bill.
And complement other features that
That's
are
right.
standing out. Like
Mrs.
it's,
Armstrong went through that with you guys. Or,
even with not newborns, with one of the patients I had at Children's Specialized, with the anoxic injury, all the nurses were complimenting him, like his mother, on how nice his eyelashes were, and she like took that to heart, and she actually seemed to feel good about it, even though he was a 14-year-old male, but it was something to her, and it seemed to mean something.
right.
It was of some comfort.
That's right. So you want to say, look at what your child can do. Wait till you see this reflex. Wait till you see this ability. Look, they're looking at you, Mom. They heard you. They know your voice already. So you know you have all these things that you want to promote that family unit. You know, so psychosocially you're doing that. Okay, imperforamus or lymphocele. Again, very common with Down syndrome and a lot of these other things. You know, sometimes you get a cleft lip, cleft palate, and imperforamus. So a broad spectrum of malformations usually, but basically what imperforamus means is that either there is no anal opening, or if there is an anal opening, it is not connected to the rectum, and therefore you have no passage of the first meconium, or the first stool. It shouldn't be the first meconium is the first, but so meconium. So that's what usually leads people to this diagnosis. And when that occurs, obviously, they need to be treated. This they cannot stay with. So obviously, they're going to go in, and they're going to connect or create an opening. And if they've lost so much of the large intestine that they can't do that, then obviously they're going to end up with a colostomy or something else. But this has to be corrected. It is fairly early. And again, it's seen by the either there is no anal opening, or if there is one and they're still not passing, it's because it didn't connect, and then they see that because there's no passage of meconium. And an lymphocele is a congenital hernia at the umbilical area. So they have a good picture in your book of this. There's actually an outpouching of intestines into like this sac. So the key here is, key. We do not want prone position, obviously, because we're going to strangulate intestines. You want to really, they pretty much go very quickly to surgery, where they're going to put the abdominal contents back into the stomach area, the cavity. I'm sorry, they put the abdominal contents back into the abdominal cavity. And close the area up. The key or the problem that sometimes happens here is that the abdominal cavity does not have enough room for the contents that have grown outside of it in this pouch. So then they can actually have respiratory distress issues, or they have to actually remove certain parts of the intestine in order for it to fit in the cavity that's there. Does that make sense? You know what I'm saying? So, and Beckwith's syndrome is commonly seen, and it's something that can occur with Down syndrome, where you see all these congenital defects. Again, go ahead, Zia.
Could the child be put on prone position after surgery?
No, these children, you want to avoid the prone position. You don't want to increase the pressure on the abdomen, so you want to keep them supine.
Okay.
Especially because you can have incision sites there, and usually they have drains there too. So, you know, so a lot of times they will actually put a temporary colostomy. You know, not a permanent, but something that then they'll reverse it later, just to give them a little rest of their intestinal tract. Meconium ileus, we talked about, so I just wanted to briefly mention again here. It's when they do not pass the first meconium stool. And Hirschsprung's disease. This is when you have a period or a space in the large intestine that you do not have ganglion cells. And what the purpose of ganglion cells are is they help to innervate the GI tract. You guys learned about these, right? They should not sound new, ganglion cells. They are actually affected by the parasympathetic nervous system. And what they do is they help to innervate the GI tract, especially the colon, to help promote peristalsis of movement through the GI tract. So what happens is when you stimulate that parasympathetic nervous system, it triggers these ganglion cells to move peristalsis and give flow through the GI tract. So what can happen, and again, congenital, okay, so it occurs at birth, is that there are spots of the colon. Could be small spots, could be large spots, that do not have ganglion cells. There's an absence of these cells. And when you have an absence of these cells, either in a small or a large area, you have a variety of symptoms you could see. If it's a large area of the colon that does not have these cells, you will have a meconium ileus, no peristalsis in that area, you will have this obstruction of feces, and if you have stool that's obstructed in the intestines over a period of time, it will start to break down because it's a warm, dark, moist area. And then it will start to build up gases, like lactic acidosis and stuff. And those gases in that stool are doing this inside of, like, you want to think of it like a balloon even, if you want to picture in your head. Okay, so it's building like this. What's going to happen? So you do not want to feed these infants. Now, some people will say, well, I knew somebody who had a child that was 6 months old with this, and that would have periods of like diarrhea that was real stringent, and they'd have periods of constipation, but they didn't have what you're saying. They didn't have this, like, you know, rupture and this, you know, no stool. And well, that's because their section that was aganglionic was small. So they were able to compensate. Their body was able to do better at certain times. Maybe if they had a high fiber diet, they had periods of constipation depending on what they were eating. Maybe they did well with the formula and the breast milk, but then when they started eating regular food, and that's usually when you see it, when it's a small section, sometimes they do very well with breast milk and formula. But then when you switch them to regular food and it starts to give them more bulk, that's when you will see this problem start to happen. And they have problems with the stools, or very string-like diarrhea they get, or they'll have constipation, of periods where they don't go well, and then when they check, they'll say, wow, they have a section that's aganglionic. And how they diagnose it is by biopsy. Okay, biopsy is what they see. So this is actually a portion of the large intestine that was removed that was aganglionic, and that is a large portion. So this was an infant, a newborn, in this case study. This was a newborn who actually did not pass the first stool, and then it all sat there, and luckily did not rupture, but could have and put them into septic shock. So that's what our biggest concern is. So if it's seen in the newborn period, you will see a failure to pass meconium stool, refusal, abdominal distension, which will continue to get larger and larger, bile-stained emesis, because again, now that everything's backing up and they're vomiting, lower area, and a constipation. And if they're older, which again is not as common, but it's probably because it was such a small area, there will be delayed growth, weight loss, a history of abdominal distension with constipation alternating with diarrhea. But even an older child, they mean like 6 months old, 7, 8 months old. They're not talking about like 10-year-olds, you know. Although they have documented cases, rare, but some documented cases of 6 and 7-year-olds even with this that were undiagnosed. More commonly in areas that don't have as well health care, or people who don't have access to health care. Usually they get a lot of pain, and you know, and again, it's seen, if it's not caught right in the newborn period, because it's not a large section, it's usually caught when they start giving them more of the table food. Or what we call like the real, you know, they go away